So again, thank you so much for the nice introduction, and thank you so much for the invitation to be here with you today to talk about the management of triple-negative breast cancer in the metastatic setting. And I will try to focus on immunotherapy a little bit, the new antibody-drug conjugates, and the role of Eribulin in this subgroup of patients, because I think that Eribulin is a chemotherapeutic backbone that might introduce many advantages when we treat this patient population. I would expect to have no more than 30 minutes to have enough time for discussion afterwards. These are my disclosures. And as we learned from the previous excellent talk, we can understand clearly that the biology of triple-negative breast cancer is complex. It's a very heterogeneous disease. And we have different subgroups that might benefit in a different way from different drugs. For the purpose of the meeting, I will not make any comments about PARP inhibitors today or anti-androgens, and I will focus on immunotherapy. That might be something interesting for the basal immune-activated tumors today. Also, the antibody-drug conjugates with sacituzumab, which has been recently approved in the US. And last but not least, I will try to make some comments about chemotherapy, which is still the backbone when we treat these patients. So let's start with this slide. So we focus on the treatment of HER2-negative metastatic breast cancer. We clearly have to differentiate between endocrine-positive tumors that we should think about endocrine-based therapy and patients with triple-negative breast cancer or resistant patients to endocrine therapy, and then chemotherapy is the preferred option. This is the data we have with the classical agents, Eribulin, docetaxel, paclitaxel, or anthracyclines, with an overall response rate in the first-line setting in the range of 30 to 45%. And this is an old slide, a very old slide by Gabriel Ortoagi, ASCO 2003, but I think that this slide is still valid. What about after taxanes or anthracyclines? There is not a clear standard of care, and many of physicians prefer capecitabine as a good option because of the toxicity profile. But we should not forget that the overall response rate with capecitabine is in the range of 10 to 20% in phase 2 and 3 studies. Other agents have included classically gemcitabine, liposomal doxorubicin, Eribulin, or others. What about ixabepilone? Ixabepilone is a drug that has not been approved in Europe, but we have two randomized phase 3 trials, both of them in combination with CAPE against CAPE single agent. Both of them achieved an improvement in progression-free survival with hazard ratios in the range of 0.78, 0.79, but it is true that the toxicity profile, at least in terms of neurotoxicity, was in the range of 23-24%, grade 3 and 4. Based on these toxicity profiles, this drug was not approved in Europe. So I think that the most important standard of care is in general taxanes-based therapy, and here is where immunotherapy has been explored in combination with chemotherapy. And IMpassion 130 was the first randomized phase 3 trial to be published. In brief, this trial randomized patients in the first-line setting of triple-negative breast cancer to receive nab-paclitaxel with atezolizumab or nab-paclitaxel plus placebo. Co-primary endpoints included both progression-free survival and overall survival. Here you can see the first of these co-primary endpoints, progression-free survival in the ITT population has a ratio of 0.80. Based on this positive data, the hierarchical model established progression-free survival in the PD-L1 positive population as the key other primary endpoint, has a ratio of 0.62 and a very highly statistical significant p-value. Based on this data, atezolizumab plus nab-paclitaxel in PD-L1 positive patients was approved in many, many countries, also in Europe. This year at ESMO, Lisa Emmons and colleagues presented the final overall survival data, the other co-primary endpoint. As you can observe here, the p-value 0.077, hazard ratio 0.87. So with the data we have, atezolizumab did not improve survival in this group of patients. Based again on the hierarchical model, although we looked at the activity in the PD-L1 positive population with a very interesting hazard ratio and a very interesting improvement in median overall survival, we did not allow to check the p-value. So then we cannot say, unfortunately, that atezolizumab improved overall survival, although the signal was clear. But it did progression-free survival, then the drug was approved. This is a second study that was presented this year at ESMO again by David Miles from UK. It is a very similar study with two different issues. The first one is the chemotherapeutic backbone, paclitaxel instead of paclitaxel. And the second one, the primary endpoint was progression-free survival, but in the PD-L1 positive population. Unfortunately, here you have the results. Paclitaxel with atezolizumab did not improve outcomes compared with paclitaxel only. And when we look at the key secondary endpoint overall survival, we can observe that also overall survival was not improved. So atezolizumab improves PFS with nab-paclitaxel, but not with paclitaxel. And this is the last randomized phase 3 study with checkpoint inhibitors in combination with chemotherapy today. This is the Keynote 355 presented by myself, in this case, at ASCO this year. Chemotherapy included nab-paclitaxel, paclitaxel, or carbogem with placebo or with pembrolizumab, a PD-1 inhibitor by Merck. Co-primary endpoints including progression-free survival and overall survival. And here you have the results. In patients with a CPS score of 10 or more, PD-L1 positive. Highly statistically significant study for this co-primary endpoint, PFS. We will have the data for overall survival next year. In 2 weeks at ASCO, we will present the data in patients who receive a paclitaxel or nab-paclitaxel. I can guarantee that this data will be terrifically amazing. A key point is about how to measure PD-L1. And there are different issues here, which is the optimal type of cell to be considered, which is the modality of scoring calculation, the cutoff value, primary antibody clones, and platforms to be used. So the key message from this slide is that we are far from knowing which is the optimal way to measure PD-L1, which is very, very clear that if we decide to go for atezolizumab, SP142 and Ventana platforms should be used. If we go for pembrolizumab, 22C3 monoclonal antibody, and DACO assay. Let's move now into the antibody drug conjugates. You all know what an antibody drug conjugate is. It's like a Trojan horse. It is a monoclonal antibody with a linker and different payloads, different chemotherapeutic payloads linked there. Once the antibody binds the receptor, the complex, the antibody drug conjugate and the receptor are internalized into the tumor cell, and once there, the drug is released by the linker break. So, TROP2 is a very interesting target for breast cancer, but maybe not only for breast cancer, but also for other tumor types. It is widely expressed in breast cancer, about 80 to 90% more or less, but it is true that it correlates with bad prognosis in many, many tumor types. Why am I showing this slide? Because this year, again at ESMO, Aditya Bardia from the Mass General in Boston, Harvard, United States, presented the randomized phase 3 study with sacituzumab govitecan, an antibody drug conjugate against TROP2, compared with physician's choice in third line or beyond triple negative breast cancer, primary endpoint, progression-free survival. Terrific data. median improvement in progression-free survival from 1.7 months to 5.6 months, hazard ratio 0.41, and a p-value very, very interesting. Key secondary endpoints, including overall response rate, moving from 5% to 35%, and look at also the overall survival. Hazard ratio 0.48, median 6.72, more than 12 months. This drug has been recently approved by the FDA in the US, still not in Europe. But now, let's move into the chemotherapeutic setting. We said before that taxanes and anthracyclines are usually the preferred options, and taxanes are considered the backbone to explore new agents in the first line setting. But these three chemotherapeutic compounds, eribulin, irinotecan, or vinflurin, have all been explored in randomized phase 3 studies after taxane, anthracyclines, and even other compounds. Let's start with irinotecan. Irinotecan was compared against physician's choice in the Beacon study. Third, fourth, fifth, or sixth line of therapy, primary endpoint, overall survival. Unfortunately, irinotecan did not achieve an improvement in survival. Second of these new agents, vinflurin, very similar concept. Heavily pretreated, vinflurin against physician's choice. Again, eribulin failed to demonstrate an improvement in the primary endpoint, improvement in survival. That's why, in my opinion, eribulin is so important, because this is the only agent that after taxanes and anthracyclines have shown an improvement in survival. This is quite a new antimicrotubule agent that was explored in the EMBRACE study. Remember the EMBRACE? Patients treated with up to 2, 3, 4, or 5 prior line of chemotherapies in a metastatic disease were randomized to receive eribulin or physician's choice. And physician's choice included everything. Here you have the results. So the primary endpoint was overall survival, and the overall survival was achieved. Hazard ratio 0.81, p-value 0.0, and the median moved from 10.5 to 13.2 months. And we can say, is it too much? Is it too little? Well, the news here is that this is the only drug that has shown to improve survival here. I don't know if this is too much or not, but it's the only one. So that's why, in my opinion, this is so important. This is a second study in the first, second, or third line against CASCADE, primary endpoints, overall survival, and progression-free survival. Unfortunately, it did not reach the overall survival primary endpoint, nor the progression-free survival. And as you can see here, the curves for PFS were basically identical. However, this study has a very important pre-specified subgroup analysis, with triple-negative breast cancer being one of them. And look at this data. In patients with triple-negative breast cancer, has a ratio of 0.70 for overall survival, moving from 9.4 months to more than 14 months. Based on this data, the MEA required a pooled analysis with all these both studies. And here you have the results. In triple-negative breast cancer, has a ratio of 0.74, and p-value is 0.006. So eribulin achieved an improvement in survival in triple-negative breast cancer patients, also in HER2-negative in general. So why? Why eribulin improves survival, but not progression-free survival? And I like this slide a lot. So here you can see two examples, one of them with capecitabine, for example, and the other one with eribulin, with a very similar progression-free survival curves. And here, you can see what's happening here. So very similar progression-free survival curves, but clear improvement in survival. So the question here is, are they producing different biological effects? Let me show you some preclinical models. What are we showing here? When we administer Eribulin after CAPE, or the other way around, what we can observe is that CAPE after Eribulin is much more attractive. Look at this data with paclitaxel. The green curve is paclitaxel followed by Eribulin. The red curve is Eribulin followed by paclitaxel. Exactly the same data with anthracyclines, much better Eribulin first followed by anthracyclines, or with vinorelbine, much better vinorelbine, Eribulin, so Eribulin better before than anthracyclines, but when we look at the same with vinorelbine, it did not happen. So something is happening with Eribulin that is transforming the tumor cell, and maybe these cells might be more active with the other chemotherapeutic compounds. So why is it happening? Because Eribulin has different mechanisms of action. Eribulin is not only a very good antimicrotubule agent that clearly suppresses the microtubule polymerization. So the point here is what's happening with the alive cells that are alive after being exposed to Eribulin. So when you give any drug to a tumor, okay, some of these cells will be dying, which is great, that's fantastic. But the point is, how is the behavior of the alive cells? Because if they are more aggressive, the overall survival could be even worse. Maybe if these alive cells after Eribulin are different, this might explain why the survival is prolonged. So let's try to explain this, explaining also the different mechanisms of action Eribulin also has. So first, when you have an abnormal tumor vasculature, and this is something always happens, that's the concept of angiogenesis, a hypoxia might induce an epithelial mesenchymal transition phenotype. In other words, when we have hypoxia, the tumor cells might become more mesenchymal. And these mesenchymal features will produce metastasis in a greater way. Now, when we compare Eribulin versus nothing, what can we observe? That these tumors in xenograft models under Eribulin treatment became more uniform perfused. So as you can see on this line, the hypoxia markers were decreased under Eribulin treatment, and the endothelial and perfusion markers were increased. So again, if we reduce the hypoxia, we are reducing the mesenchymal tumor cells. And here, what can you see? Exactly what we are saying. We are increasing the epithelial markers. We are decreasing the mesenchymal markers. How does it correlate with outcomes? Let's go again to different models. We can observe here that we have less migration under Eribulin compared with 5-FU, and less invasion, again, compared with 5-FU. Let's go to mice, and let's administer to these mice 5-FU or Eribulin. And what happened here? Look at the lungs of these mice. When we compare the control with the 5-FU, 5-FU did have less lung metastasis, but a few. When we look at the data with Eribulin, the number of lung metastases were clearly lower. So maybe you are not decreasing the progression-free survival curves, but we are decreasing the aggressiveness of the tumor cells, and they will be able to metastasize in a different way, and this might improve survival. So I'm just concluding. So We have also some data with Eribulin in combination with pembrolizumab, beautiful data from Saad Tolani from Harvard University and colleagues. Look at the overall response rate, 40% and 32% in the first or second line of treatment in triple-negative breast cancer, which is the overall response rate we have with Eribulin only here, between 12 to 20% more or less. And also we have some beautiful data with Eribulin in combination with pembrolizumab in ER-positive metastatic breast cancer. Overall response rate in the range more or less of 30%, 35%, with a median progression-free survival of 6 months. It is true that we have some small randomized phase 2 data in the ER-positive field that maybe pembrolizumab does not induce a huge improvement in progression-free survival. So I'm just finishing. So if you have good drugs, you have immunotherapy here, you have antibody-drug conjugates, you have Eribulin, when should we administer this drug? As soon as possible? Or we can delay the use? This is the CASCADE experience. And what can we observe? That at least for triple-negative breast cancer, only 47, less than 50% of patients will receive a third-line therapy. 94 of them will receive a first-line setting, 65% will receive a second line, but only 47% will receive a third line or beyond. So in my opinion, the better, the earlier. So Eribulin, I think, is a single agent that has demonstrated improvement in survival and is a clear backbone to optimize potential drugs. So these results have established Eribulin as the best option for second line and beyond in patients with triple-negative breast cancer and metastatic disease. And that's all I wanted to share with you, my friends. Thank you so much again for the invitation. Thank you.